Thank you, everyone. I'm delighted to be here today, and thank you very much for that introduction. I'd like to start by acknowledging that we're meeting on Aboriginal land, always has been, always will be Aboriginal land. I'd like to acknowledge the traditional custodians, elders past, present, and those emerging, and all Aboriginal and Torres Strait Islander people here today. I'm presenting on behalf of my colleagues that I work really closely with and key community partners that I also work closely with. And we work on a program of research that is interdisciplinary, and it centres on improving the lives of women, girls and young people affected by injury, homicide, violence and trauma. Some of our research covers analysis of fatal violence trajectories, co-design of health system and cross-sectoral innovations. We have a focus on integrated care and in particular culturally safe and trauma-informed care. And we also really focus our research around advancing our understanding of the social and structural determinants and depathologizing how we view trauma, in particular intergenerational and cumulative trauma. This is just a brief overview. I'm going to look at the health impacts of violence against women and also outline some of the key priorities from the Women's Health Strategy and how this aligns with, as Rosemary said, some of the key projects that we're working on. And then look at the fourth action plan and where there's synergy there. So there is a growing awareness of the health impacts of violence against women and girls, as well as the social and the economic impacts. Domestic violence is the greatest health risk factor for women in Australia aged 25 to 44, and it costs the economy in the vicinity of $22 billion per year. We know that 1 woman is murdered each week by a current or former partner, and 8 women are hospitalised each day due to assault from a partner. There are also impacts in terms of non-communicable disease, sexual and reproductive health, mental health, smoking, alcohol and other drug use, and chronic pain. There's also an emerging focus on the neurobiology of trauma, and in particular the impacts on emotional regulation and coping, but also the cognitive impacts on memory, decision-making, safety planning, and even how we tell a cohesive story. What we also need is a stronger focus on the social context of violence and trauma, and in particular, the cumulative life course and transgenerational impacts. There are lasting intergenerational impacts for children who are exposed to violence, and children are frequently described as witnessing violence. However, this is vastly inadequate for the experiences of children. We also need to look at critical system and service gaps that prevent people from seeking and accessing help. And we need to recognise that the health system plays an important role in responding to and preventing violence. And of course, we also need to consider the role of the social determinants, but we need to understand this as both a consequence and a cause of violence and trauma. I'm probably preaching to the converted in this room, but for the record, an intersectional approach is needed to address violence against women and girls. An intersectional approach recognises that social identities and experiences are layered and that there are additional barriers to accessing support for people and communities. So if we look to the Women's Health Strategy, there are 3 key priorities for addressing the health impacts of violence against women and girls. The first is to raise awareness of the health impacts. The second is to address health impacts. And the third is to co-design and deliver safe and accessible services for women experiencing intimate partner and or sexual violence. So the first project I'm going to talk to you about is the Preventing Femicide project, and this aligns with Priority 1 around raising awareness. So this was a research project that we partnered with Counting Dead Women Australia. Counting Dead Women Australia was launched in May 2014 by the researchers of Destroy the Joint. For those who aren't aware, this is a femicide census that is sourced from community researchers. It aims to focus the attention of both public and policy makers on preventing the unnecessary and premature death of women, as well as the pain and suffering of victims, families and communities. And I want to acknowledge their immense work in this area. So this is my colleague and the co-founder of Counting Dead Women Australia, Jenna Price, and I think this quote is very important. When you cover one death at a time, it looks like it's segmented, that it's not connected, but it's actually part of a huge problem. So we've done a number of projects in this area, and this tends to revolve around in-depth case reviews of fatal violence. We want to gain insight into the social context and the pathways from non-fatal violence, but we also want to understand the health needs and identify service contacts and gaps. So on the left here, This is the paper that we published in 2018, and that was the one based on the partnership with Counting Dead Women. But today I'm going to give you a bit of an insight into our latest project, which this one we've focused on New South Wales, and we've sourced data from the National Coronial Information System. We've gone back as far as 2006, and we've done an in-depth case review on 81 of those cases. So for this one, with the Counting Dead Women project, we looked at all violent deaths, so that included stranger and acquaintance perpetrators. But for this one, we focused just on intimate partner and family violence because we really wanted to look at that trajectory. We used a mixed methods approach. So in the National Coronial Database, there's basic demographic and incident information. And then attached to each case is a number of reports from toxicology, autopsy, coroner reports. We've also sourced legal and media reports. So even though the sample size is quite small in terms of we've looked at just 81 cases, each case has a vast amount of data attached to it and can be as much as 100 pages. And so then we've looked, I have looked through all of those reports and basically developed a larger data set that tracks the trajectory leading up to the incident, as well as the health needs and pathways and other service contacts, and looked at also at informal supports for people. What we can see is that lethal violence is never simply the tragic result of accumulating stresses that see people snap. There are always patterns and missed opportunities for prevention, and these are across multiple sectors beyond the health system. In our sample, we could see that there was frequently escalating violence in a lot of cases. However, in over a quarter of cases, neither person was known to perpetrate violence in the relationship. And what this speaks to is the need to really rethink what this looks like, because it's not always physical or overt violence. There was multiple instances where the predominant type of violence was more around coercive control, jealousy, stalking, elder abuse, financial and technology facilitated abuse. The other thing that emerged was that the role of informal supports are critical, and we really need to think about how these networks can be better supported, so friends and family. So while there were evidence of physical and mental health crises, the data was not complete, and we really do need a better understanding of health pathways. We also need for health professionals to understand the nuances of family and intimate partner violence and how this presents. There certainly was a relationship with the social determinants, and if you're in the last session on mental health, we had a lot of discussion about this. And there was also, often the triggers were around accumulating stresses relating to financial hardship, legal, property or custody disputes. The second project that I'm going to share with you is the First Response, Integrating Trauma-Informed Care in Health Settings, and this aligns with Priority 2 in the strategy. This is a research partnership between 4 Aboriginal community-controlled health organisations, Katungal, Illawarra AMS, Waminda, Yeren, and it was funded by the Lowitja Institute. So this project came about based on conversations with the services and with women with lived experience, but also looking towards the policy context in which you can see there's very strong recommendations for trauma-informed care, but it's not clear how this can be done in an appropriate way for Aboriginal and Torres Strait Islander women and what that even looks like. So this is a program of research that explores how culturally and trauma-informed responses can be integrated across and within services and how this informs approaches to care for women. So what does it mean? What does it mean to be culturally and trauma-informed? It means understanding the context and impact of colonisation, cumulative, transgenerational trauma, as well as current-day trauma. It means that the multiple complex nature of women's lives need to be understood and responded to without judgment or indifference. And it means that services really need to understand and work from this standpoint and not simply impose a Western or biomedical model of trauma or therapy. I won't go into too much detail here, but First Response is a number of different research activities. Today I'm going to focus on presenting some of the results from the yarning interviews and the knowledge translation workshops. There's also some pictures that you'll see from our digital scribe, and this was a really important way of translating the information that came through in the project into a way that could be easily adapted for community, but also for policymakers. So this was the interviews. This is a picture from one of our yarning circles. And again, we wanted to talk to the workforce and understand better what their conceptualizations of culturally and trauma-informed care were. So it became really clear that the art shows, there's one of the key strengths about art shows is their comprehensive integrated service delivery model that has soft entry pathways. And this is key to responding to women right throughout their journey of healing and also in times of crisis. It was really important that the clinical and case management teams were so closely integrated, and this prevents re-traumatisation and minimises the amount of times women need to retell their stories. And this also sort of goes out into the community too, because staff from the art shows act as advocates, and that also minimises the amount of times that women have to tell their story. This is just a really key quote. How do we ensure that people aren't being asked the same question 10 times as they go through from one worker to the next? How do we ensure that what the doctors are doing is right? And how do we really understand that it might have taken them everything to get here, to this place, to be here today? So key people, each of the services had go-to people, and these people were seen as the experts in their service, and they were really key to facilitating not only support for the woman, but also for ensuring that the teams worked well together. And it was important that services not only found these people, but retained them and supported them and make sure that they were able to do their job as well as they could. Key to this was supervision and self-care, and there were some challenges for people around this, but this was really critical to preventing burnout and vicarious trauma. Supervision was important, but also working within a strong, cohesive team with effective leadership. Involvement of government services can be re-traumatising, and the art shows minimise this by building strong partnerships with police, housing, legal, justice and community services. However, this takes considerable resources, and this is not well recognised in key performance indicators, particularly within the primary health network frameworks. The other issue that emerged around partnerships was racism. Art show staff frequently witnessed or encountered racism in mainstream and government services, and sometimes this was directed at clients and sometimes this was directed at staff. The third and final project I'm going to share with you aligns with Priority 3, and this is the Illawarra Domestic and Family Violence Trauma Recovery Service. This is a project that's really close to my heart, and I'd like to acknowledge Sally Stevenson, who's here today, the manager of the Illawarra Women's Health Centre. So emerging research shows that trauma must be treated at a cognitive, emotional and physical level. However, currently services tend to focus on crisis intervention with less emphasis on and very little resources provided for long-term recovery. Essentially, the system is designed to respond to high levels of physical violence, and there's limited ability to address emotional and psychological needs. And these needs are often more complex and require long-term care, and the system currently, as it stands, is not set up for that. So to address this, the Illawarra Women's Health Centre, as I said, spearheaded by Sally Stevenson, has coordinated a community-led campaign to establish an evidence-based service that provides integrated multi-sectoral support. The aim is to transform services by focusing on the emotional, psychosocial and physical impacts of trauma, and it will become a centre of excellence to lead the research into the long-term effects of and recovery from domestic and family violence. So this Trauma Recovery Centre actually fits within a broader community collaborative initiative that's starting in the Illawarra at the moment. It's essentially a community reinvestment model which sits along both primary and secondary prevention initiatives. And even though the centre itself is set up as a tertiary response, it's important to acknowledge that it will also contribute to primary and secondary preventative efforts by preventing re-victimisation and supporting women in their recovery, and also addressing the intergenerational impacts on children. From a research perspective, what we want to do is ensure that the establishment and design of the centre is embedded with evidence. So we want to identify effective interventions, including emerging technologies and innovations that the centre will be designed around. We will embed co-design into the centre, model of care with experts by experience and practitioners. Thank you. And we will establish a framework for evaluating the ongoing impact of the centre. Taking it back to the fourth action plan, there are 5 key priorities. There's a big focus on primary prevention, but I guess what we want to sort of talk more about today is the fact that primary prevention is a long-term goal, and in the here and now, there's a lot of women who need immediate support for long-term recovery. So where to next? From a policy and systems perspective, yes, we need an intersectional lens and we need to centre diverse voices to ensure that policies and systems do not embed marginalisation. There are huge challenges with data, but this is essential for monitoring and evaluation, and we need to get this right. We need consistent definitions of family violence, and these need to be consistent across jurisdictions, but we also need improved data collection. From a services perspective, we need better integration of services and coupled with appropriate training and workforce support. At the community level, communities have this knowledge. We need to draw on that existing strength and knowledge. And importantly, we need to listen to the voices of survivors, centre their voices, and ensure that policy and service delivery is responsive to the needs of women and their families, and especially those who are at greater risk, who face additional barriers to accessing support. And we need to acknowledge that much more can and must be done. Thank you.
Thank you. So I'd like to start by acknowledging that we meet on Ngunnawal land and pay my respects to elders past, present and emerging, and any Aboriginal, Torres Strait Islander, South Sea Islander here in the room today, people here in the room today. And I'd also like to acknowledge that sovereignty has not yet been ceded and may not ever. So here I share some of the results from the Reproductive Coercion white paper, which was called Hidden Forces. Murray Stopes Australia worked collaboratively with 80 organisations across Australia to publish this paper last year, and I'd also like to acknowledge that many of you are here in the room today. In terms of defining reproductive coercion is the control or constraint of another person's sexual and reproductive decision-making. So, is reproductive coercion an impact of violence against women and girls, or is it a form of violence against women and girls, or is it both? Key stakeholders each define reproductive coercion differently, and it's like any new terminology. Language varies depending on the sector and the standpoint. Reproductive coercion is coercive control over another person's bodily autonomy. It includes things like fertility, coercing or forcing someone to use contraception or to be sterilised or to conceive. It includes coercing or preventing someone from accessing contraception or sterilisation options, particularly younger people. It includes pregnancy outcomes, so coercing or forcing someone to continue with a pregnancy, threats or violence to induce the termination of pregnancy, or coercion towards abortion in a clinical setting. It includes preventative health outcomes and much broader population health outcomes, such as coerced contraception or sterilisation in preventative healthcare contexts like pelvic pain, menstrual health, or gynecological cancer. It also includes broader access to sexual and reproductive healthcare, so interfering with someone's social, emotional, physical, or financial capacity to access sexual or reproductive education, justice, or health, including mental health. Reproductive coercion exists within interpersonal and structural domains. So here's a quote from a contributor to the Hidden Forces white paper. "I always felt that what was happening to me was wrong. He wasn't beating me, he wasn't mean to me. He just would not wear a condom. In every way, we had an equal say in our relationship. Apart from contraception, to name what happened to me helps." Structural forms of reproductive coercion include laws that reduce a person's ability to access healthcare, lack of funding or lack of public health provision of services, or gender equality, particularly when it leads to economic disparities. Every year, protesters outside of our Midland Clinic in Western Australia affect the healthcare experience of 2,300 women. There's an interplay between the interpersonal and the structural aspects of reproductive coercion. Reproductive coercion is more prevalent where the abuse of power is structural. So here's two more quotes I'll read out. "From a young age, I was taught that my only purpose in life was to give birth to the next generation. And if you wanted to have an abortion, you would need to hide it from your community for fear of being shunned. You don't have a voice and you don't have control over your body." To analyse rates of reproductive coercion, we look at a number of data sets internally at Murray Stopes. The most thorough reproductive coercion data is available from our National Counselling team. In 2018, Murray Stopes provided almost 2,000 counselling appointments. Of those appointments, 965 were women who attended pregnancy choices counselling sessions. 1 in 3 of those clients were living in coercive contexts, and of clients who were Aboriginal and Torres Strait Islander, 1 in 2 were living in coercive contexts. Women are more likely to identify coercive contexts at certain weeks of gestation. The pattern is consistent regardless of whether it is the first or a subsequent appointment. So a client can attend any number of appointments, they're more likely to identify coercion at particular gestations. From our data, it shows that coercion is most likely to be reported between weeks 10 and 17. There are clear links between poverty and reproductive coercion. Choice Fund beneficiaries undertake comprehensive screening for financial hardship and prevention screening for coercion. 4 in 10 clients seeking financial support at Maurice Stopes to access healthcare are also experiencing violence. Primary, secondary and tertiary prevention of reproductive coercion requires understanding the drivers of reproductive coercion. We're currently writing a strategy for the primary prevention of reproductive coercion in our own clinical settings. This considers individual and systemic barriers which occur within informal and formal aspects of a patient's life. Nationally and in these spaces, we need to be advocating for individual and systemic enablers that prevent reproductive coercion. Reproductive coercion rates are a key measure of success for the National Women's Health Strategy. Across sectors, we're currently in the stage of awareness raising. We're translating theory to practice. Importantly, right now, we don't need to be raising awareness amongst the public. We need to learn from the challenges that emerge within the National Plan to End Violence Against Women and their Children. Firstly, we need to collect data. We need to do a lot more research. We need to understand the context better. And we need to boost the capacity of services to be able to respond effectively. Because when we start public awareness raising, we will get more people coming forwards and we need the capacity to respond. The prevention of reproductive coercion is intrinsically linked to all priority areas in this strategy and requires a life's course approach. To prevent reproductive coercion, we need to develop holistic care pathways, monitor comprehensive care mechanisms, and collaborate between women's and men's health models. Australia needs genuine collaborative partnerships to actively prevent reproductive coercion. Currently at Maurice Stopes, we have a new online research policy and practice publication, which you're welcome to sign up to, or you can email me and I'll send you the link. We're investing in some new research partnerships. We're involving consumers in the co-design of clinics, including a national integrated trauma-informed care model. In 2020, we'll be holding a reproductive coercion roundtable in Melbourne. We'll be doing quarterly practitioner webinars and online meetings, and we'll be investing in moderated online peer support spaces for clinicians and nurses. And the key thing is, in looking outwards, we must look inwards, and our primary focus in the health sector needs to be looking at reproductive coercion prevention within our own clinical settings, understanding what's happening, publishing that data, and getting a better picture of what's happening nationally. At Maurice Stopes, we're happy to support any national advocacy work and want to encourage collaboration in spaces such as these. Thank you.
It's always that awkward silence. Do I clap or should I wait to hear if she's any good? Hi everyone, I'm Jen. I don't have any spreadsheets because, how can you put I got the shit kicked out of me on a spreadsheet. And plus I'm really bad. I've seen that clicker. It scares me. So yeah, I'm awesome. I'm New South Wales Woman of the Year. Woo, I'm still riding on that almost 4 years later. I graduated from uni with a bachelor's. Last year I've got 3 awesome kids, one of which I foster, but he's mine as far as I'm concerned. And I started a charity. I feel like I'm kicking a few goals and life's pretty good. But in 2011, 2012, and to be honest, 2013, psychologically, I was still in a domestic violence relationship with my now ex-husband. Thank God for that. You might have got, I'm pretty unprepared and I sort of joke about a bit. I like to say, if I'm going to do something, I do it properly, and I did with domestic violence. My ex ticked every, on the DV wheel, he ticked everyone. There was sexual violence, financial violence, emotional violence, physical violence. whatever ones I've missed. So I like to say, yeah, I did it properly. I did the full tour. I still have issues from my ex-husband. He lives overseas, and I still get a lot of issues from him, and threats of defamation, and my employers get it, and Jean Hales might get it now, so watch out. You could be one of the chosen few. So usually I come up and I speak about, DV and how it affected me and how I sort of overcame those obstacles and blah, blah, blah. Here I'm just going to whinge to you about my medical history, basically. I don't think it does it here. So I was thinking about this on the drive down from Sydney today, and I was like, okay, I suppose I better figure out what I'm going to say. And I was thinking about my actual physical injuries, and then you sort of think, well, hang on a sec. This is really important as well, because although not all of my physical injuries have healed, nor will they ever heal, unfortunately, they're better, and I'm functioning, and I can walk, and I can talk, and go to work, and all that type of thing. But the emotional damage and the mental health, and even now I'm still realising things going, oh my goodness, like, oh, that was pretty full on. I still have days where I'm just like, you know what, today's not going to be my day. I'm just going to stay home and I'm going to watch some crap show. Marabella Mansions is awesome for that. Because I can't do it, because someone has said something to me which has triggered something where it makes me think, oh, yeah, okay, maybe I'm a fake. Maybe what he told me all those years we were married, because this is a man I loved and I trusted so much that I had children with him, that I committed to marrying him. I committed to spending forever, or whatever that means nowadays, with him. So I trusted and, respected everything that he said. And domestic violence, people need to understand, it is not about getting smacked about. Yeah, I got a lot of that, but it is about the erosion of self-confidence. It is about power and control. And I still get really upset and really angry about that, because even to this day, I feel like I'm a victim. And I shouldn't, but I do. But you have to acknowledge that. And I think as a health professional, even if you're treating someone who could be, like me, I'm 7 years out. Or if you're 20 years out, I speak to women who are 30 years out and they still have those days, and it sucks. And you need to recognise that as health professionals. And I think, a lot of people have trauma in their lives. However that may look. But this is a special kind of crazy sometimes. I'll take it down a notch, wow. My ex-husband, I presented to hospital 3 times during our relationship, to the emergency room. I'm like a really crap liar. For me, the majority of the violence, it started when I stopped work when I was 8 months pregnant with our first child. The first time he ever put his hands on me, there were those signs as usual, but you think, oh, I'm about to have a child, I trust him, all that type of thing. I didn't feel I had a connection with the local, when I go and do my maternity checks, because it's always someone different. You're rushed in, you're rushed out. I didn't feel I had a connection to say anything at that point. First time we disagreed over vaccination, he thought it was a conspiracy with the government and the pharma companies. I don't know. And I was like, oh, you're really crazy now. And he grabbed me by the throat and he raised his fist. I remember it. And I just went, oh, shit, what have I done? I've just stopped work. I'm relying on him, physically, emotionally very shortly, because I don't know who has kids, but I was not prepared. I was like, oh, my God, I'm about to have a baby. I should have, researched this a bit more. And I thought, oh, this is pretty scary. And I didn't know where to turn, because I felt trapped. I honestly felt trapped. And I felt ashamed as well. So with Belle, which is my 8-year-old now, it was only that one time he physically assaulted me. With Harvey, it was a lot different. Harvey is now 7 years old. He is taller than his sister. He is very healthy. He's very smart. He's a good kid. He whinges way too much, but it is what it is. I presented 3 times to hospital when I was pregnant with him, from when I started being pregnant with him, to about when he was 6 months old. First time I showed up, my wrist still hurts. husband at the time had twisted me he did some sort of martial arts and made him feel tough, did some martial art move on me, and I got a hairline fracture in my wrist. I didn't seek further treatment because I was scared what he would do. And why did you explain that? And I said, I fell. Then I got hit across the face with a kettle. And then when I fell to the floor, he stomped on my back. I was about 7 weeks pregnant at the time. My jaw still clicks. It's a really great party trick. I don't know if it'll do. Yeah, I know. So you've got to find the humour in this stuff. Otherwise, I'd be down the bar right now. See, alcohol. It is really, you got to get good support. So I remember going to the emergency room. It was very late. I felt, because I was like the whole thing, seeing stars. I had concussion, I'm sure of it. Obviously my jaw was slightly dislocated. My stomach, all I cared was like, is this baby alive? And I went to the emergency room and they triaged me. How'd you do it? Oh, I was training with, because I used to do martial arts, but obviously not good enough with this idiot. I was training and I got kicked in the stomach and, I felt funny. And like, what a dumb excuse. And I'm making, I'm thinking on my feet, but I feel as well I was saying that because I needed someone to say, hey, are you okay? Because if that's the case, then okay. But if it's not, far out, man, like we can help you. We can refer you to people. So they triaged me, then they put me back out because, I wasn't bleeding to death. I sat there for 2 hours, bawling my eyes out. And even though I've had a bit of a tear up here, I'm usually a little emotional robot. I am made of steel. And I sat there bawling my eyes out because I was so scared my baby was dead. And they left me there. And then I went in and they're like, oh, yeah, whatever. Yeah, you'll be fine. If you start spotting or you're bleeding, just like come back in a day or two. Doppler's not on at the moment. You're too young, you're too early to have this done. And I was like, oh, okay, so you go back to the abuse. And no one said, are you okay? Like, why are you bawling your eyes out? Like, and there's different ways to say things. And then the third time I went to emergency, Edward kicked me in the stomach when I was 6 months pregnant and hard. I had a placental bleed. I had, a nice big bruise, and I had Harvey had an elevated heart rate. And that was my worst interaction with the health system because I went there and again, you go to triage, you sit around, you wait, blah, blah, blah. They finally see you, and I remember this young female doctor and I'm thinking, oh, yes, I've got a young female because I'm stereotypic. I was stereotyping and I shouldn't have done that. And she said to me, oh, I see you've got another child, because I had a 10-month-old as well. I said, yeah, I do. And she goes, well, where's she? I said, she's at home asleep because it's about 1 a.m. in the morning. Well, what are you doing leaving her there? Because I sort of hadn't disclosed who had hurt me, but they kind of put it together. I said, I don't want to talk about how I got hurt. And she said, why didn't you bring her with you? I said, she's fine, she's asleep. I can't believe you put her in that danger. And I had to get my medical records for different things recently, and in it says patient becomes defensive and aggressive and leaves without further treatment. No shit, Sherlock. You just called me a bad mum and didn't offer me any way out, just saying, why the hell are you leaving your child there? So that was really horrible. As a health professional, I know I've got short time. Long term, like I told you I'd whinge. I'm missing a tooth because I can't afford, or then I couldn't afford to get a proper root canal. There's not proper systems, You go on the waiting list and, I just thought, well, it's cheaper to get the tooth out because I can't afford it. I don't have private health insurance because my ex-partner, I had blue ribbon, all the rest of it because I love sport and, lots of sporting injuries. He refused to pay for it after I'd had children. So now I turned 38 yesterday. Yeah, happy birthday to me. But if I get health insurance today, it's 16% loading on my private health insurance until I turn 65. And I think there needs to be some sort of leeway. And I know this isn't, but this is a health outcome. I've got a knee that I need surgery on, which isn't related to, it's a sporting injury. It is not related to domestic violence, well done. One thing that's not a result of that. But I have 2 slip discs from getting hit with the kettle. And I can't go and get my surgery at the moment because I don't have private health insurance. I can't go and get this checked as regularly as I probably would because I have 3 kids, I have a mortgage, I have bills to pay, I need to go to work. I don't have private health insurance. So this is something as well we really need to think of when we get to policies and we're talking to governments. There needs to be some leeway. So if you're on a single parent payment or you do have domestic violence, you've got to be given some sort of, I'm not saying give everyone forever to get back on, but give them a 5-year or a 10-year grace period, because I'm paying that loading and it might only be, an extra $10 a week, but that adds up over the next 30 years. And it's a constant reminder that I couldn't afford to do it because of the violence that I was in. I would love to see all health practitioners be able to have training built into their education. I need them to be connected with their local community because every community is different. Every community has different groups. There's so many things that I'd love to see. I think it's amazing everyone is here. I'm sure I'm like 1,000 minutes over time. 31 seconds to go. I think it's amazing that I was invited here just to ramble about my various medical ailments. If you're concerned, don't be afraid to ask. Be gentle about it. If you're not confident, speak to a mentor, speak to someone else, call the DV hotline, call someone that you respect who can help you do that, because if you don't say something and that woman ends up dead, or the next time she comes, she's got a dislocated jaw, she's got slip disc, she's been kicked in the stomach. I'm not saying you own that, because you don't. Only the perpetrator owns his behaviour and is responsible for his behaviour. But you can do everything in your power in a sensitive and calm manner. Some people, they will go back. I went back. But you need to give them that opportunity as much as you can and be connected with your local services as well. So thank you so much, everyone. Let's go change the world. Thank you.
It's been a very, very informative discussion. Alison has the task of summarising, and I am very glad it's not me, but I wish you well.
It's extremely challenging to try to summarise this session, wouldn't you agree? I just concur with what everybody said, and I think it's actually been covered really well. I don't know if you all agree. I actually think it's been quite comprehensive. I think, firstly, it's just acknowledging that, yes, violence against women is prevalent. It's obviously prevalent in the community, so it requires a public health response for that reason, because it's everybody's responsibility. So we all need to know what our roles and responsibility are, and those roles and responsibilities need to be formalised, and they need to be measurable and accountable in terms of having outcomes. And I'm always reluctant to use all these concepts, but they are intersectional, and I don't think they're just intersectional in terms of from listening to all of you, it's not just intersectional in terms of, it's different and diverse impacts that require, those tailored and targeted responses, whether it's Aboriginal women or cowled women, or, but I also think it's very, very clear that, and listening to your great presentation too, is that there's a lot of barriers as well that are intersectional, whether they be economic, and I think that if we don't address those things, that they're also, if we're not enabling women to live safely through, say, economic security, for example, then, the governments are complicit in that violence if we're not having a proper public health response. And I also think that it ties into what somebody else was saying about that recurring victimisation, that research shows very, very well that there is recurring victimisation, but it also shows that that's actually primarily for girls who are, say, experiencing childhood sexual abuse, and then they are much more at high risk of experiencing ongoing re-victimisation. But usually if there's, say, poverty and other barriers, and I think if we know that and we're not intervening where we know that those girls are at much higher risk, I think that we are complicit in that violence. In terms of a health setting response, I think that it's actually identifying what those different roles are and making it compelling such that health has to respond. And we know we've got the evidence, we've got terrific evidence that's using that evidence effectively.
Yeah.
And well, has anyone else got anything to add? It's a lot to, there's so much. I'm so worried that I'm not going to do justice to.
I think you've done very well. I would add one thing. It would be it would be essential to map the points along the health system continuum that women and violence connect with the health system, and then look for the evidence of what's done, what's not done, what the gaps are. And then we'd have a very strong case to make for what should be done. So that's another thing to add to the list of what actions can we take and what can't be done without collaboration. Can I ask you all to thank our panellists and presenters, but also